Welcome to Treatment Information Exchange. Today's program is going to be about lipoatrophy and how to solve that problem. And I have today two distinguished doctors who are going to give self-introductions at this time because I think they would do a better job than I would. And we'll start with Dr. Antoniskis.
My name is Diana Antoniskis. I'm the lead physician at the Immune Deficiency Clinic at Kaiser Permanente, and I've been in the HIV field for about 15 years now.
I'm Greg Fowler. I've been HIV positive for about 18, 19 years, and the issue of lipoatrophy, I've seen it affect my friends, and I probably have had some form of lipoatrophy for about 5 or 6 years.
Doctor?
I'm Marla Klein. I'm a dermatologist. I'm in private practice at Klein Dermatology and Associates, which is in Tigard, Oregon, and I started doing SCULPTRA to treat HIV patients for lipoatrophy shortly after its release last year in August 2004.
And I think the best way we can start the program is probably just to give a little bit of background on, well, I mean, I'm also living with the same issue, but maybe you could kind of talk a little about the treatments that are used and how some cause, some don't, what are other options rather than the facing that issue.
Well, you know, it's interesting, Fred, because several years ago when we got active antiretroviral therapy, you know, people were not really, prior to that time, people were really not living long enough to develop some of these complications. And so once our therapies for HIV got better, people lived longer, and now we see some of these long-term complications. Really, there are pretty much two different syndromes. There's the lipohypertrophy, which means fat accumulation, which you tend to see more with protease inhibitors. Then there's lipoatrophy, which is actually fat wasting, which probably is more associated with different nucleoside drugs like AZT and D4T specifically. Xerit or stavudine seems to be the drug that's most commonly implicated with the fat wasting in the face. And I think now that we really recognize that, most clinicians are sort of moving away from using that, particularly as a first-line therapy, because we know that the longer period of time that someone's on this, the more likely they are to develop the facial fat wasting. So I'm hoping that as we become more sophisticated and we learn more about some of the long-term side effects of antiretroviral therapy, that actually the incidence of facial lipoatrophy will go down.
Yeah, and the other choices, I mean, you might want to cover some of the other choices that we have now as opposed to, I mean,
right. Well, in terms,
yeah,
in terms of nucleoside reverse transcriptase inhibitors, there are several. There's tenofovir and abacavir, and actually several studies have shown that by changing from a regimen that contains D4T or stavudine to a regimen that contains abacavir, people actually start to gain weight back. Unfortunately, most of the time it's not enough that you really notice it clinically or that you can really measure it. So, but we do, as you said, have several, at least 6 or 7 other options to use instead of D4T.
And also, if you remember back when we were doing the D4T, I mean, there was only a few drugs to bump together anyway.
Right.
And I think I remember, well, what I was on was D4T, DDI, and hydroxyurea, which was kind of like the kiss of death.
And I think me and
Or the
Fred were
devil's
true
child, as they
in
say.
that case. I could show pictures where I was actually on those 3 drugs plus about 4 others, and it worked good for about 3 years, but then it's just crashed all at one time, and a lot of my lipoatrophy happened in a period of about 6 months, and my hair fell out, and it's funny, your body can only tolerate, it's willing to tolerate so much, and then it says no more.
Well, and again, most of these changes are related to the length of time on the drug. So the longer you're on it, the more likely you are to have some sort of change.
And that's part of the thing, is that people are under such distress because of their changes.
It's so profound.
They'll try all these different alternative therapies, and it means switching therapies. Earlier this year I switched away from D4T, and I had a viral load increase because of that. And But at that time, I thought it was probably worth it. You know, I just said, you know, I'm tired of dealing with it. I was thinking about having the sculpture done. So once it was done, I did not want to lose the benefits of having that done, which is the, you know, restoring some of the face. And I think, you know, so many people make that decision. Do you see a lot of your patients make the decision to change away, even though it's not medically advisable for other reasons?
Or even to stop their therapy, which I think is
maybe
the
worst
most,
of all, not telling you.
right.
Yeah.
I think sometimes people just can't stand to look at themselves in the mirror anymore, and so they say, you know, that's enough. I can't live like this. And then, you know, frequently, as you say, they won't feel comfortable sharing that, and so
Yeah,
I think
and you know,
And they don't tell you a lot of times.
Greg and I were, you know, we always lament on certain people that really have a dramatic, you know, facial fat loss or body habits change.
And I think you can't, you know, overemphasize like the social stigma you feel when you have lipoatrophy, and I think that's a very important issue. Like, I can go to the gym or I can walk around on the street, and it doesn't have to necessarily be Castro Street in San Francisco, but walk around the street in Portland, and you could see, you said, oh, he's on the HIV drugs. You don't know that they're necessarily gay or they have AIDS or anything for any other reason, but you can look at their face and you can tell right away. When I first came out, you know, finding HIV or even having AIDS, I still have a choice in the matter. Somebody could look at me and tell if I, you know, had HIV and AIDS, and it was still my choice. But when lipoatrophy happens, it's no longer a choice. You go out in public, you know there are lots of people who are going to be able to look at you and tell right away, yeah, he has HIV.
Well, you talked about people not wanting to go out in public, and it certainly hit home to me when I have a lot of people that, you know, are in the field of AIDS and doing some work and different businesses and so forth that I would very much like to have on this program won't come on this program because they don't want to be, you know, maybe they still want to go out in public, but they don't want to necessarily show themselves on television.
It's another issue when it's your face and you're dealing with AIDS, and of course the attitude that, well, you look that way and you deserve that. You deserve that to look that way.
There are a lot of people in business today that, I mean, that's where I know most of the people that are saying, you know, I needed to do this because I'm in sales or I'm a person that's dealing with the public, and I have to look good. I have to look healthy. You know, and you don't want to. They don't want to look gaunt because that's not an attractive, you know, scenario. And the thing I feel mostly about is people that are younger. I mean, I'm an older person, but there's a lot of younger people, and it's a shame when you see that, and the person is still, and they're probably still working, or trying to maintain a job, and sometimes even getting a job with the employer, maybe looking at it a little with a jaundiced eye. You know, there's a lot of ramifications that are, what you might say, indirect to this stigma that may, you know, affect people quite dramatically.
And you're talking about people's vanity to a certain extent, and that doesn't just apply to HIV. So that's kind of how I come into all of this. I'm not an HIV specialist, but I've been a dermatologist who's worked in cosmetic dermatology for 11 years, and people come in because their acne makes them feel stigmatized, or their psoriasis makes them feel stigmatized, or so dermatology and cosmetic dermatology, but you know, anything to do with the skin that other people can see that embarrasses that person or interferes with their ability to interact with people is really, you know, kind of why they come to us. So it's, and everybody has a different place where they reach that point.
I definitely wanted to make sure we set the stage as far as, in fairness, all the products that are out there. There's a lot of products that, as we covered the drugs that cause and that avoid this, I think we also need to talk about the products. And I know a couple of people that had it done in Tijuana, which is the
It's the bioacrylamide.
Yeah, I've had a couple patients in the past. One actually went to someone in Southern California, I believe, and got a cadaveric fat transplant from a cadaver to them, and they actually did not have a very good outcome. They got a big infection, and it really didn't turn out very well.
Was that an FDA approved, or they just kind of did it off-label?
You know, I'm not sure. I think it probably was not
that
FDA.
in Mexico?
No, that was in the United States.
Oh, really?
But and I have had several people that, and there are several people that have gone to Mexico.
That's for the bioacrylamide.
Yeah, I think that's.
Yeah,
And have you had many patients? That's not an FDA approved, and I've seen it on a lot of the websites.
They're applying
and for what I see it from the websites, and people in general, a lot of people are very happy with the, sticking this polymer or whatever it is in their face, but it's just, my concern is, what, 3 or 4 years down the road,
It starts to
it's gonna
sag
do.
and hang.
Well, interesting that you had mentioned that. I just saw someone that had that done, and they've got a lot of asymmetry in their face. I mean, one side is really puffed out, and the other side has sort of, I don't know if it didn't take on that side or what, but.
Well, with this product, and you'll more technically describe it, but it doesn't. It seems to be that you can balance and you can adjust, and over time, correct anything that might have been, because it's an art, I guess, in a way, to get everything balanced in a proper way.
What about implants, where they cheek implants or things like that? Have you heard of
I
any?
actually haven't seen anyone with cheek implants, have you?
It's an option, but it's not a soft option. It's both plastic and silicone implants, and so they're.
It seems like if you don't have a lot of fat in your face, you put an implant in there, it's just going to bulge out and not look natural, like you've got a.
Right, skeletonized, sort of still.
And these things have been going. I went on websites for the last 3 or 4 years, just looking at options and reading message boards, and I think there's several I had put down, like there's a great place called facialwasting.org, and we might have, and they explain all of these options there. And there's another users group, it's a Yahoo users group, and it's a health group for Pause Health, and I think we'll put a byline there. And it talks about a lot of people who have tried a lot of these things. We're here for the long term, and a lot of us didn't think we'd live more than a year or two, but now we're finding we're living like 10, 15, 20 years. So
you have to put every piece of what we're talking about at the point in time when it was used.
Unfortunately, part of the problem of being sort of on the cutting edge of a new disease is that we are learning about it, and we're learning the right ways to treat it, and we don't really know things until they've been around for a while. And kind of on that vein, I know that SCULPTRA and NuFill have been out in Europe for a long time and been used for a long, what's considered sort of a long time, I think 5 or 6 years, but we still don't know, what could the implication be 15 or 20 years from now if you get a SCULPTRA done. I mean, we really don't know that. And is there an interaction between that and HIV drugs? Well, we don't think so, but there are a lot of things in HIV we didn't think were a problem, and they became a problem. So,
Yeah, but is our best option right now for people who's been waiting for 2, 3, 4 years, and it's really affecting their choices about if it was between go off your D4T or these meds that are causing these problems, or deal with SCULPTRA. I just have to.
Right, and I think it has to be an individual decision, because every person
yeah.
has a different comfort level with doing things that you don't know what the long term.
Yeah.
A NuFill, as it was called, started in Paris, I guess, France, and the doctor over there introduced it to a doctor friend of mine in South Florida by the name of Dr. Engelhard, who championed it, more or less in this country, and really was, among other things, an advocate. But he was an HIV treating physician, much like yourself, who decided that I guess this was going to be his niche, and he went for it. And and I guess he kind of brought it along quite a bit. And then now it's I guess what was it, a year ago? It was a year ago.
Last August,
a year ago.
There is a training process, and I think you were telling me you had went through it.
The Dermot company, which I think is very noble and wise, is that their stance is that they don't want to sell the product to anybody until after they've gone through training. Training can be as simple right now as viewing a couple of DVDs that take a couple hours to view. That's kind of the initial way to get in. And then they also have Dr. Danny Vlagar from Paris, France, who's come through the United States a couple times, and getting to spend a whole day with him and watching him do injections and talking to him about his experiences.
Going the training, I noticed there's a lot of dermatologists and plastic surgeons and probably other medical providers who are possibly doing the training right now. Do you feel like it should be somebody with a higher level of expertise?
I think somebody who's really comfortable with a needle and levels of the skin. It has to be placed at the reticular dermis subcutaneous fat junction. If you're comfortable with a needle and you have a cosmetic eye for the face, then I think any doctor could be trained to do it.
Can you talk a little bit about how many injections you need and how far apart and that kind of thing?
So polylactic acid is actually considered a dermal stimulator. It's imagine a piece of sand, and that little piece of sand in the oyster is going to stimulate layers and layers of collagen to wrap around it, and that collagen is then going to be what the filling agent is. So the polylactic acid is minute and will go away, and it comes as a powder form, and we add some sterile water to it and some lidocaine to it to make a 5 cc volume to use per vial. And the body then is going to absorb all that water and lidocaine and leave just this powder behind. So what Greg was talking about was, you know, people are you're filled with water at the end of a procedure. Like with Greg, we would do 10 cc's. You know, that looks pretty good, 10 cc's of water all over the place. But then that goes.
So you do 5 cc's on each side?
So we'd actually do 2.5 and 2.5
okay.
and 2.5 and 2.5. So you'd split up 5 cc's to do the cheeks and split up another 5 cc's, for instance, to do the temples. You can't lay down too much because then it will, it kind of binds together and makes lumps. So you have to be able to try to.
Because people say that they get lumps, so you have to teach people how to do massage and.
Right.
And that's the binding part of it. That
Yeah, so if it clumps up, then that little piece of sand all clumped together isn't going to make the collagen it needs to make, so you're going to get a subtherapeutic response, but also you're going to feel this little BB in the skin as opposed to just feeling kind of a normal skin thing. So the procedure is to come in and, for an HIV patient, typically if Dermic is supplying the SCULPTRA through the program that they have for free, we'll use as much as we can, which will be a maximum of 10 cc's in one visit, and then we'll bring them back as soon as, and that's going to depend on the patient, it can be anywhere from 3 to 6 weeks later. The worse off they are, you know you're going to need more volume, the sooner you can bring them back. The cosmetic patient, we're going to want to wait at least 6 weeks on, because you're going to see something at 6 weeks, but you might still continue to grow more collagen. And so if it's really a fine-tuning thing where you don't want to overdo it and create deformities, then you're going to space those treatments further out.
But if it's still if what you're trying to do is grow collagen, is there really an advantage to doing it sooner? I mean, do you grow collagen at a faster rate? Or what's the rate to grow collagen?
So in the studies that they were doing, it sounds like they were doing them as close together as 2 weeks apart.
Right.
So we don't know what the advantage is, other than you don't want to blow it by sticking too much in there.
You could go longer. If somebody had to pay something for this treatment and they didn't come up with the money, they could wait a month or 2
Correct.
or 3.
If you were
But
paying out
no,
of pocket, you could wait 6 months to a year before your next treatment.
and that might bring up the thing is this is an expensive drug. It's like for the 2 vials, which is typically what people need for a treatment. It's like $1,000.
$2,000.
$2,000. Oh yeah, and then for the treatment, that's just for the medication itself for the treatment.
Yeah. Oh, right.
Device.
Yeah. Just for the device itself is this. But Dermic will cover the cost of the drug if you can call their number, and I think we'll have that up there and you can get up to 6 kits, which is basically maybe six treatments, because if you use 2 vials
Provided that you meet certain income
their
criteria.
income eligible is up to $40,000 a year. You get the kits for no cost. $40,000 to $80,000 a year. There's like a sliding scale fee.
But again, I think you have to make the point that you don't want to just get the drug. You have to
Paid
somehow
it,
have a
inject
way to have someone else inject it, and that will cost money.
Yeah, and that will
Because
cost money. Yeah.
most insurance companies, there's only one I know in the Portland area that will cover this.
Listen, we have to roll the footage that you did before we get too far along here.
This is my lobby of my building. That's my nurse, Marcia, speaking with Greg and preparing him for the procedure. Photographs are very important. Patients require a lot of patience because this is a slow process. Multiple treatment sessions. Here, showing Greg where we plan to treat that day, and I'm using a marker to kind of plan out how much volume I'm going to put into each site.
To go back to work if you have really fair skin, because the bruising is a lot more noticeable.
Take some more.
People vary quite a bit from leaving completely unbruised looking to leaving as if they were beaten up. And that depends, it seems, more on the skin type of the patient than my
Or maybe the doctor.
technique. Yes. Greg is one of the fortunate ones who doesn't seem to bruise very much. That's
Or get the lumps.
the white particles are the polylactic acid, and they're dissolved there in the water. I'm using a 26 gauge needle, 1/2 inch long, to inject into the skin, reaching right at the plane of the reticular dermis and the beginning of the fat layer, basically, at the very top of the fat layer. And we're going to spread out small increments using 0.1 to 0.2 cc's into each site. And once we've injected each of them about a centimeter or so apart, then we'll use massage to create a smooth plane at the subcutaneous layer of that polylactic acid material. In the temples, it's a different situation. It needs to be placed under the temporalis muscle, and so those shots can be a little bit more sensitive. The nice thing about SCULPTRA is that it's a very neutral product, and so it doesn't have a lot of burning or stinging as it's injected. Greg here didn't even use a numbing gel. We just did it straight from straight out. Tough guy. A lot of folks will give some numbing gel too, or if you actually pre-treat with numbing with a local anesthetic like a 2% lidocaine, that stings a lot more and is a lot more painful than the SCULPTRA agent is itself. It's a roller coaster ride for the patient because they'll come in, they'll get injected, they'll look pretty full, they'll feel pretty good about that, and then that's going to disappear over about a week's time, and then they're almost back to where they started, depression. And then as it starts to grow, it doesn't always, from what I've heard from some patients, it doesn't always grow during that 2 to 6 week time period at an even pace. It can look lumpy, sort of, like, you know, some areas will grow a little faster than other areas, and so it won't look quite as even as the end result might look. And so they have to have some faith and kind of put up with that for a bit, but when they come back at 6 weeks, then it will get tuned up as the process goes on.
And I have to say, I'm right now the third to halfway through the process. So it's, you know, it's just and like you said, it is a process. You have to be patient, and some people might not, you know, get that great results, and you got to accept that too. But I think the majority of people I have seen, I've known a half a dozen people, and you know, they would let me touch their little cheeks, and I said, wow, this is really amazing. You know,
sorry, it's nice to touch it though, because it's actually, I mean, you can't feel a foreign object in there like you can with a lot of other fillers we use in cosmetic dermatology.
And they showed me pictures beforehand, and it was quite a dramatic difference, and that's what encouraged me, you know, when we had looked at it.
Yeah, it seemed like Greg was more hollow, and he already seems to be kind of getting some of this in here. So.
But it's like I say, some people notice, and a lot of people don't notice, and it's just like, well, I just got to be happy and move on myself. So, but you know, but other than that, and I know this process to try to get this covered and treated like a reconstructive procedure, not as a cosmetic procedure, realizing that.
And I would say, you know,
disease process that has happened.
Yeah, and the reason that it's covered in California and not here is because the state law in California is much different than it is here, and there actually is a state law that says you need to, all insurance companies have to cover, I don't know how it's phrased exactly, but complications of medical therapy. We don't have that state law here, and so, you know, we actually have done an extensive amount of research, and in the Portland area there really is only one company that covers it, and that's because they're also in California.
So, but I think this is an opportunity for people to at least learn about this product, and I think you know, there's a lot of other options, or not a lot, but a few other options out there. You know, I think Greg and I have both agreed that this is, at least we see this as maybe the best option, you know, the most reasonable, and it is something you have to redo from time to time.
Correct.
They call it touch-up.
Every 2 to 3 years, but some of the people I've known, it's worked for been in 3 years, and they still, so it's just individual, you know.
And the application, the number of treatments, so they say on average 3, but that's, you know, probably more than that.
I think it's more like 3 for cosmetic patients
Yeah,
and
and
probably 5 or 6
6 for-
potentially for the HIV
Especially for those that are
patients.
deeply affected, you know,
Exactly.
that have, really
It's
hollowing.
gonna-
And I wonder if it affects anybody a little differently for those that have had this issue for a while, or as opposed to people that have recently. And that makes no difference, probably.
Yeah, we
I
had
don't
some,
think we know yet.
Yeah, well, time will tell, probably, so. Well, I really appreciate y'all for coming here and taking time out of your busy schedules and your appointments, and Greg for putting this, kind of coordinating the project. And I thank everybody for watching Treatment Information Exchange.